to set the context for why we're talking about collaboration and the importance of collaboration, I first wanted to get into addressing the challenges of behavioral health and why collaboration really is key and critical. And not just the challenges, but really what are the opportunities in behavioral health. So let's go to the next slide, Laura. So, often when people think about mental health, they think about individuals with a mental illness. And I really like to show this model because this model, I think, really shows a more complete picture. It shows a dual axis of mental health. And on one axis, you can see one end that really reflects high levels of mental illness. So an individual with a serious mental illness. And then on the other axis, you see sort of low levels of mental illness. And then on the other axis, you see great mental health, so really flourishing with your mental health. And then on the other end, you see poor mental health, so sort of languishing or not doing well. And then the boxes, which I imagine are probably maybe hard to see or hard to read what's in the boxes, really just describe kind of what it's like to be in these different places along this continuum or in this model. And so what's important here to understand is that a person with a serious mental illness can experience good mental health because their mental illness is being treated, it's being managed, they're getting the supports that they need in the community. And then a person with no mental illness at all can be experiencing very poor mental health. And so, it just really reflects the complexity when it comes to our mental health and the needs that people have, and shows sort of a bigger picture of mental health and why it's important to have a full range of partners. Let's go to the next slide. And, we know that mental health problems are the single largest cause of disabilities in the world. Together, an estimated 20% of lost healthy days are due to mental illness, and globally, only an estimated 10% of people who need attention or treatment for mental health problems receive it. In Colorado, the picture is pretty similar. So according to the 2019 Colorado Health Assessment, 15.3% of Coloradans reported poor mental health, compared with 11.8% in 2017. Now, additionally, 26.9% of Colorado adults said that they or a loved one or a close friend had been addicted to alcohol or drugs in their lifetime. Mental health is as important as physical health in consideration of overall health. Poor mental health or mental illness increases the risk of many chronic physical health conditions like stroke or type 2 diabetes or heart disease. Similarly, the presence of chronic conditions can increase the risk of poor mental health or mental illness. So this slide here shows the continuum of behavioral health and where different partners might have a role along that continuum. Individuals can move along this continuum with regard to their need, and communities really should be equipped to offer programming and services along this continuum. So from community-based prevention programs and the promotion of good mental health, early identification of issues with mental health or substance use and early intervention, all the way through treatment, potentially residential services or acute care, and recovery and relapse prevention. So let's go to the next slide. And then I wanted to point out here, also in Colorado, there are, and this is true across the nation, this isn't unique to Colorado necessarily, but there are additional challenges along that continuum that have been very well documented, and significant reform efforts that you've heard about already this morning are underway in Colorado. You're going to hear about it even more a little bit later. Dr. Werthwein's going to dive into that. We've got a pretty fragmented system that we're going to do a lot to address. workforce shortages, a lack of integration in a lot of ways. A couple that I'll point out around the integration of mental health and substance use treatment, as well as a lack of integration around behavioral health and physical health care. And then something that you hear over and over is just the stigma, not just the stigma of behavioral health conditions, but the stigma of seeking help for them. And that's just to name a few. I've got up there the links to where this information is. As I said, it's very well documented. So a needs assessment was conducted by HMA, and there are several documents related to that at that second link. And then the efforts of the Behavioral Health Task Force and the blueprint around behavioral health reform, that link is also provided there. Douglas County leaders have been really involved in these efforts. So a lot of thanks to Barbara Drake, who was part of the task force, the executive committee, and continues to be involved in the executive committee for behavioral health reform. Chief Duffy, who was involved in the behavioral health task force, and all of your commissioners are involved at the state level, providing leadership to the opioid settlement dollars that are coming. Commissioner Thomas and Commissioner Teal and Commissioner Layden providing a lot of leadership at the state level. And I know, HMA has been very involved in behavioral health efforts with the state. And I know the state's looking to Douglas County and has looked to Douglas County for your excellent work in behavioral health and the excellent work you do in community collaboration as a model. And forgive me for my sniffles. Let's go to the next slide. So, as I've said, mental disorders for mental health, along with substance use disorders, they play a role in poor physical health and chronic illness. Mental and substance use disorders, trauma, obesity, smoking, chronic disease, all of those things are linked. And although we don't commonly talk about them this way, many mental and substance use disorders are themselves chronic diseases. They're rooted in complex, interconnected, biological, social, and psychological risk factors. And to effectively address the challenges of behavioral health in our communities, we need cross-sector, multifaceted strategies that are coordinated, that are non-duplicative, that are mutually reinforcing, that are measured and improved upon, and that tap into the strengths and resources of partners that are coming together around a shared goal. That's what Douglas County's been doing for many years. That's what all communities should be doing around these issues. So that means, we have health systems that care about behavioral health, that are involved in trying to do something about behavioral health, justice systems, education systems, workplaces, CBOs, community-based organizations, social services, public health, and others have a stake in behavioral health outcomes. And there are many passionate people who want to make a difference along the continuum. So what do we do about that? Let's go to the next slide. So one framework that I like to use and promote a lot, it's not the only framework, but I think it's a good one, is collective impact. There's a lot to be learned from collective impact as a framework. It supports going beyond just coordinating activities or just collaboration. It goes beyond just sort of, coming to a meeting and sharing what your organization does or reporting out. It actually requires a little bit more than that. And you can see here on this slide, I won't read every single one, but sort of what's at the root of collective impact is that it's really structured. There's certain conditions that need to be met for it to be collective impact. And it involves a shared understanding about what the problem is that you're working on, that you're trying to do something about. There's shared agreement about how you're measuring your progress and accountability for that progress. Equity is really at the center of the work. And it really involves recruiting and co-creating with community members. And that's something that I've really seen in Douglas County with your DCMHI, this cross-sector partnership and this co-creation of the work, of the activities, of your priorities. And that's critical to having collective impact. Let's go to the next slide. And so these are the 5 conditions for collective impact success. And again, as I mentioned, it's more than just collaboration. So you have that common agenda that you start with, right? It becomes your North Star. It is what you're moving towards. And it is your shared understanding of the problem and your common goal. You have a shared measurement, and it's not just measuring the outcome, it's measuring your progress along the way, and it's your shared accountability, how all the partners hold each other accountable for where you're headed and for the progress you're making. You have mutually reinforcing activities so that you're ensuring that what each partner is doing is not duplicating what you're doing, and that it reinforces what one another is doing, and that it best taps into the strengths and the resources that each partner brings to the table. You have continuous communication so that you're building trust, so that you're aware of what's happening and you're aware of what activities are being implemented. You're aware of how they're mutually reinforcing. That continuous communication is very important. And then perhaps most important is a backbone organization. In the case of Douglas County, that is the county. And man, they're doing an outstanding job just really making sure that things stay coordinated, organized, and moving forward. Let's go to the next slide. And so when you have that coming together, that strength of collaboration that is centered around having collective impact, shared impact, you really move things from individual action, the success of one organization in the space of behavioral health, to really making significant system change and then ultimately population change. And that's something we're seeing in Colorado with the significant reform efforts that are happening right now. This is not just the success of CDHS or public health or the justice system or HICPUF. This is really going to be collective impact across the state. And we are going to see significant system change and ultimately population change. And that is something that you're also seeing in Douglas County. And so that this movement towards more significant change. Let's move to the next slide. So I wanted to share with you just some examples of effective collaboration. And really show you both at a large scale, at a national scale, all the way down to a local level. So this first example here is the overdose response strategy. This is at a national level. This is an effort funded by the Office of National Drug Control Policy and the Centers for Disease Control and Prevention. It's a collaboration across public health and public safety, which are two entities that are very, very different, right? And they came together to address opioid overdose. And what they found is that law enforcement or public safety really understood that they weren't going to arrest their way out of it, out of this issue, and that they were feeling very frustrated about having to respond to arresting or to providing naloxone to reverse overdoses to the same people over and over. And really getting sort of compassion fatigue around that. And public health really understood that they weren't going to be able to implement effective harm reduction strategies or prevention strategies without engaging law enforcement. And so these two sectors came together in a highly collaborative effort to share data, to share insights, to really look at trends in overdoses in order to develop shared strategies for addressing them. So it's a great example. A link is provided there if you want to learn more about it. In Delaware, another great example of multi-sector teams and cross-sector sort of strategies. CRTs are community response teams. They came together originally to set up what's called points of distribution to distribute naloxone to reduce or to reverse overdoses, opioid overdoses. And they've now expanded their work to include all kinds of things, prevention activities, education campaigns, and it's a round up, really localized effort that engages businesses, nonprofits, the health system, law enforcement, government agencies, individuals with lived experience. So it's a beautiful example of all kinds of partners who come together and regularly work together around the opioid crisis in Delaware. And again, a link is provided there if you want to learn more. Next slide. And then another example, also in Delaware, funded by the state, it's called the Community Wellbeing Initiative. Again, another great example of lots of partners coming together to address a really difficult problem. So this one was addressing individuals who were struggling with substance use, but who didn't access traditional services or formal services, and who really needed all kinds of support around social, economic, and emotional kinds of needs in order to successfully address their substance use. And so what this group did is they put in place community well-being ambassadors. And these were individuals who lived in the community, who came from the community, who could reach out to these individuals who were struggling as ambassadors and connect them to services. And they really had that built-in trust and could break down those barriers that were related to stigma around the system. And that really came from this sort of ground up approach and having all these partners at the table. Next slide. And the final examples are from Colorado, because Colorado just grows great work and stuff here. The first one is the Colorado Consortium for Prescription Drug Abuse Prevention. That didn't start out as a collective impact initiative, but it has since been evaluated for that and found to be effective for that. And that is again a cross-sector, both public and private partners addressing prescription drug abuse and for opioid stimulants and sedatives, and bringing together lots of different partners across state agencies, academia, and others. And so you can see the description here, the different work groups that are involved in that. And that's really grown and done some great work. I forgot to include the link here, but you can find that information if you just Google Colorado Consortium. And then finally, last but certainly not least, is the DCMHI itself. HMA has been working with the DCMHI for about 3 years. And when we started and helped the DCMHI to create the blueprint that they are now working with, it was very clear to us that it was a beautiful example of collective impact and just a truly unique collaboration. So that unique community partnership is a great sort of moniker, because that is truly what it is. And really, to have a successful collaboration, you have to have folks who come to the table and leave their egos at the door, leave their agendas at the door, in service of the greater community good. And that is what is happening with the DCMHI. It is really just a sense of commitment to the whole continuum of behavioral health and commitment to the whole person's health. And when folks come to that table, that is what their commitment is to. So with that, I'm going to turn it over to Laura, who's going to tell you more about the DCMHI and that collaboration. Thank you.
Thank you so much, Shannon. Hi, everyone. I hope I'm coming in clear. And if I'm not, I trust someone will pop into the screen and let me know that they can't hear me. appreciative of your introduction to models on community collaboration and how they can affect real change in communities and impact health outcomes. So quick introduction from me. I'm Laura Ciancone. I coordinate the Douglas County Mental Health Initiative. I had intended to be present today. Certainly wish I could be there with all of you, but life happens. And I'm very appreciative of the team behind the scenes who made a quick switch to allow this virtual option to happen. So thank you. And let's hop in. I'm going to talk a little bit about our model in Douglas County. So quickly, a bit of history. The Douglas County Mental Health Initiative was launched 7 years ago in June 2014 with the support and leadership of our county commissioners and county staff, following and in response to a few serious tragic events that happened in and around Douglas County, which Commissioner Thomas spoke about this morning. And what was really hoped was that through coming together in partnership, we could improve the health outcomes of Douglas County residents by addressing unmet mental health needs, connecting people to services, expanding access to care, and preventing those who were in need of supports and services from falling through the cracks of the mental health system. So after gathering as many perspectives and partners as possible, the Mental Health Initiative began its collective journey to understand the challenges, understand the gaps, where there was duplication, but also where there were opportunities to collaborate and make a real difference. So in preparation for today, I've been reflecting on the conditions that allowed the Mental Health Initiative to flourish. And so for this part of the story, I'm drawing on the experience of my colleagues who've been in the initiative since its early days. And so even though this may seem small, the process mapping that happened at the beginning of the initiative had real impact in the success of the initiative long term. So as Shannon mentioned through her observations, partners came to this initiative with the primary goal of learning versus owning or defending the way that the system was or wasn't functioning. There was transparency, humbleness, openness, and a commitment to understanding the system as it was before making any effort at all to change it. We rely in the initiative on support from over 44 organizational members across 20 plus stakeholder sectors, which span health systems, the justice system, the education system, first responder agencies, payers, community-based organizations, social services, public health, and more. It's quite a diverse bunch of partners, but what we do have in common is an interest in improving mental health outcomes for Douglas County residents. And without a doubt, it is the representative partnership in the initiative that has been the glue for the past 7 years. So Shannon described just a couple of minutes ago, we also use a collective impact model in the mental health initiative. So when it comes to partnership, we think and believe that all voices matter and are certainly critical to ensure that our efforts are supportive of one another, both by reducing duplication, but also so that we are effectively leveraging the talents and strengths of each partner organization. We recognize that no single entity can do this work alone. So indeed, all of our programs and all of our strategies have multiple perspectives at the table, from the design phase all the way through implementation and evaluation. Since its beginnings, we have had a keen eye towards breaking down the silos of communication or those parts in the system that put up blocks on communication. So in that regard, we've had a very close and unique partnership with our county attorney's office And many of our partner agencies have committed their own compliance officers to make sure we're constantly talking about ways that we can effectively share information and build a network system of care, which has a real impact on the quality of life of individuals in Douglas County. And ultimately, what we are looking for in the initiative are willing partnerships and getting to yes. A product of our blueprint for an integrated community-based mental health delivery system, which was created by the Mental Health Initiative. There's a link below this visual, and this is also on our webpage. It's very similar, or recognizes kind of similar aspects as the dual access model of mental health that Shannon presented, in that it recognizes that our health and well-being is flexible. On any given day, as humans, we change as our circumstances change. So naturally, our system of care, to be effective, needs to move along a continuum and be responsive to our needs. So our collective work is not just about crisis. It's not just about individuals living with mental illness or substance use disorder. We are also focused on the community-based work, the preventive health promotion activities. We care about primary care. These settings play a major role in identifying behavioral health needs through routine screening and can assist in connecting individuals to early intervention support. And we are focused on crisis, on acute care, and on specialty behavioral health supports and recovery. We operationalize our multifaceted, faceted coordinated strategies outlined in our blueprint through our governance structure, which you can see here. We're guided by a common vision, supported by the broad mental health initiative. Our strategy is guided by the steering committee, and our work groups are really where the rubber meets the road. And these align with priorities outlined in our blueprint, which are creating a network system of care, rebranding mental health and substance use, interventions to address gaps. And our steering committee has taken on the big heavy lifts of workforce and policy. So I wanted to share a couple of examples of how some of our core programs are creating system change through our model of collaboration and the initiative. And the first is the Community Response Team, or CRT program. The revolving door of crisis through the 911 and emergency medical system was a gap identified in our early process mapping. And from that, the CRT was born in 2017 as the first program launched by the initiative. To date, our teams have served over 4,000 individuals in Douglas County. They have diverted over 1,000 crisis encounters away from emergency departments in favor of direct placement to inpatient facilities or crisis stabilization units. Or many people are even able to remain in the community or at home with safety planning and follow-up. Jail has been avoided in over 500 cases, and collectively nearly 4,000 first responders have been relieved from the scene of a crisis and sent back into the community where they can protect the public's safety. And we estimate conservatively that the CRT program has avoided and cost $6.46 million over the last 4 years. And another example of how we believe the CRT is creating system change is a decrease in 72-hour mental health holds that we've seen through the sheriff's office. So as you can see, after years of steady increases in mental health holds, when the CRT launched in 2017, we started to see a decrease. And we're not aware of any changes to protocol, policy, practice, other than the implementation of the CRT at the time. And the decrease that we're seeing in 2020, we think is probably more likely tied to the pandemic The average monthly M1 count for 2020 was around 45, and we're seeing so far in 2021 an average of 53. So it's coming back up a little bit, but still wanted to give this example because it has trended down since the CRT was launched in 2017. The CARE Compact, which launched as a pilot in December 2020, offers the next ring of support around the CRT program and serves vulnerable adults with co-occurring mental health needs, substance use disorders, intellectual and developmental disabilities, and safety net social determinant of health needs like food and shelter. This data is from a survey of case managers and care coordinators from our 10 partner agencies. So anyone that was involved in a CARE Compact team working with an individual was surveyed. And we were looking for input on whether the CARE Compact was reducing duplication of services, improving transitions between levels of care, improving access to appropriate services and levels of care, addressing gaps or barriers to treatment, and the ability of the CARE Compact to address social determinant of health needs. And we can see that in all cases, the majority of respondents believed that the CARE Compact had a positive impact on streamlining coordination of care. And to Shannon's point about shared measurement and accountability, this is the kind of data that we collect for our programs to make sure that we understand how they're running, but also know where we have room to grow. But so far, the CARE Compact has served over 20 individuals, and we are seeing positive impacts on quality of life. In addition to those two programs, our work groups have supported the Let's Talk Anti-Stigma campaign by sharing messages via social media. And we've localized the campaign through filmed PSAs with our Board of County Commissioners and with local youth, both in English and Spanish. And a working group of the initiative created a web-based app, which creates an access point for information, self-screeners, health assessments, and treatment and support services in mental health, substance use, intellectual and developmental disabilities, and general well-being. All of these resources are categorized by age group, and they're all age appropriate. And we are currently focused on a pilot with youth aged 13 to 17. So again, in reflecting on what I think makes us so unique in Douglas County, why our model works, these are a few things that come to mind for me. Timing. The foresight of county leaders to create the mental health initiative in 2014, and also the willingness of all of you as partners to jump on board, really positioned the county and the mental health initiative ahead of the curve. We have been prepared to respond to rising challenges and the needs of a rapidly growing county. This group launched one of the first co-responder programs in the state and has remained a model for co-responder programs that have come since. This group created a thorough blueprint outlining strategies to address gaps and now stands ready for the reform at the state level to pave the way for local solutions. Partners and governance. So yes, diverse, there are many of us, but again, we are all united around a common interest to improve health outcomes for Douglas County residents. Every single one of us, through both personal and professional experiences, have witnessed the gaps and challenges present in the behavioral health system today. And we care deeply about making a difference and making it work for people in Douglas County. Having a backbone, having dedicated staff to drive the work and maintain momentum is key. And our initiative's commitment to data collection and analysis and having those targeted work groups that really can dive into topics and projects, that is key to our success as a collaborative. We are action-oriented. Certainly, this group has been incredibly proactive over the years in identifying gaps and then doing something about it, actually turning that knowledge into action, launching programs, gathering data, making an effort to understand what we can do better. We are dedicated to programs that are impactful. And this impact we can see through our data. The things that we tackle are relevant, they make a real difference. And because this initiative has been so focused on collecting stories, collecting pieces of information, and sharing that with partners in the community, we can really tell the story of how this group is making a tangible difference. So really, to all of you, all the partners in the room, everyone joining via live stream, this is possible because of you. Very little of what I talked about today would have happened without your passion, your dedication, and your presence. So thank you seems like such a small thing to say, but just sending everyone abundant gratitude and thanks. This day is about you, and I hope that each of you enjoys the summit. So thank you all very much, and I will turn it back over to Commissioner Layden. Thank you.